Hello, my name is Flávio Dias Silva. I am from Brazil. I am a professor of psychiatry at the Federal University of Tocantins. And as a former family doctor, I am especially delighted to share with you some of my thoughts about somatization in children and adolescents. Somatization is a common phenomenon and frequently not a chronic or severe problem. However, as well defined by the American Psychiatry Association, when a person has a significant focus on physical symptoms, such as pain or weakness, to a level that results in major distress or impaired functionality, we must consider the diagnosis of somatic symptom disorder. In this condition, the individual has excessive thoughts, feelings, and behaviors related to physical symptoms. The symptoms may or may not be associated with a diagnosed medical condition, but the person feels sick in an excessive or out of proportion way, and that's the trouble. In these cases, at least 3 points I consider very important. First, perhaps a psychiatrist's main job is to be willing to discuss cases with pediatricians or other primary care providers. Children with somatic symptom disorder typically are brought to primary care physician rather than a psychiatrist because individuals and sometimes their families may experience difficulty accepting that their concerns about the symptoms are excessive. They usually continue to be fearful and worried about having an unidentified or even serious condition. So this can lead to unnecessary and even dangerous clinical investigations and treatments. In addition, this may affect the physician-patient, physician-family relationship and led clinicians to even develop bad feelings towards that family, as well as to physician burnout. So, planning case discussion programs, regular seminars between general doctors and psychiatrists, and even providing clinicians with burnout support programs can be very useful in the global management of these conditions, in my point of view. The second point is knowing how to approach that patient who arrives at the psychiatric office. One tip I would give is that in the first consultation, the psychiatrist must act like a general practitioner first, trying to understand the patient's clinical history, performing a physical examination, analyzing the complementary tests performed, and talking about his clinical opinion on the situation. This can help greatly in establishing a good relationship of trust with the patient and family. From psychoanalysis theories, we have learned that patients with this disorder usually have anger from disappointments and rejections, so they express it by claiming the help and concern of others and then dismissing them as ineffective. So we must keep an eye to establish a good relationship as a first goal. And the third point I would advise is try the patient-centered medicine as the case formulation framework. Person-centered medicine, especially studied by the Canadian physician Murray Stewart, has four basic principles. First, understand the experience of being sick. This means focusing on the damage, the impairment that the person is having due to the disease, and thus joining forces in order to face these impairments and not just to target the symptoms themselves. Second, we must know the child adolescent as a whole, not only the biopsychosocial aspects like comorbidities such as anxiety and depression, family problems, social relationships, but also investigate about child adolescent life's vision. This will demonstrate our genuine appreciation appreciation for who the patient is. The third component of person-centered medicine is making a joint plan to cope with the illness. Remember that patients with somatization often seek more listening and acceptance than a magical solution to their symptoms. Provide appropriate psychoeducation about the nature of the disorder, its cause, and talk about the eventual family and appropriate response to illness. All this is of extreme value. Do not run fast towards psychology, but avoid excessive medicalization and invest in non-pharmacological techniques such lifestyle modifications and stress reduction coping strategies. Lastly, the fourth principle of patient-centered medicine is to strengthen the doctor-patient relationship. Once this patient needs a richer emotional life, it's important to establish a secure, attachment-based doctor-patient relationship. Maybe this is the case where we can offer a closer contact, acting as a general practitioner if the patient has not one. Just like some general doctors sometimes act like psychologists or psychiatrists. I hope these ideas can help you, and I wish you all the best for you and your patients.